Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing a patient with Parkinsonism and urinary symptoms. It's a 75-year-old woman. Symptoms are nocturia, urgency, and frequency. She is having Parkinson's disease, hypertension, and hypothyroidism. The urinalysis was negative and the post-void residual urine is 270 ml. Imaging shows no obstruction. So the questions are, what are the possible causes of these lower urinary tract symptoms or LUTs in this patient, and how to approach and manage this case? So neurogenic bladder, this is a neurogenic bladder and it is common in Parkinson's disease. It is especially in patients with multi-system atrophy. So we go into understanding the problem of this patient. The bladder has mainly two functions, or only two functions. One is storage of urine, it is storage, and another is emptying. The storage symptoms, inability to store leads on to urgency. That is, patient has got a desire to pass urine. Second, frequency, and sometimes nocturia. Post-void residual urine is usually 50 to 100 ml. So, increased PVR indicates impaired bladder emptying. So, this patient has got a dysfunction in the storage of urine. At the same time, there is a dysfunction in the emptying of the bladder. Post-void residual urine greater than 200 ml suggests incomplete bladder emptying and warrants further evaluation. Only three important causes. One is neurogenic bladder, second is outlet obstruction, third is Detrusor underactivity. This can occur in diabetes cystopathy. So let us look into Parkinson's disease and bladder dysfunction. Parkinson's disease usually causes Detrusor overactivity that leads on to urgency and frequency. So this is a common symptom, Detrusor overactivity leading on to urgency and frequency. At the same time, this can produce impaired Detrusor contraction leading on to incomplete emptying, also sphincter dysfunction also. So two ways, there can be storage dysfunction. At the same time, there can be emptying dysfunction. Both are affected in Parkinson's disease. LUTs is common in Parkinson's disease, characterized by Detrusor overactivity, leading to urinary urgency and frequency. But impaired Detrusor contractility can also cause residual urine. So that is what you have to understand. What does the residual urine mean? High PVR, that is 270 ml here, indicates significant incomplete bladder emptying. So it is a likely underactivity related to Parkinson's disease. So normally the post-void residual urine is less than 50 to 100 ml. More than 200 is definitely abnormal. So patients with neurogenic bladder due to Parkinson's disease have mixed symptoms of overactive bladder and impaired voiding. So this is something that you should remember. There is a patient can have overactive bladder evidenced by frequency and urgency and frequency and impaired voiding. So in this patient, what he should not do, be cautious in giving antimuscarinics like oxybutynin. When there is a frequency and urgency, there is a tendency to give a bladder blocker, that is antimuscarinic drug, to inhibit the detrusor contraction. but this will lead worsen urinary retention. So already the patient has got the post-water residual urine is 270. So giving him oxybutynin will worsen the symptoms. So if detrusor and underactivity is dominant, bladder training and intermittent self-catheterizations are preferred over antimuscarinics. That is a take-home point in this patient. So in the next step will be you train the bladder. Behavioral strategies, intermittent catheterization. But again, remember, in patients with significant incomplete bladder emptying, clean intermittent self-catheterization or CISC is the mainstay of treatment to reduce urinary retention and prevent upper tract damage. Hope this point is clear to you. So next best step, as mentioned, initiate CISC. But again, if there are persistent symptoms after addressing retention, then cautiously we can give low dose of antimuscarinics or mirabegarone, that is a beta 3 agonist. But you should monitor the PVR. So the final answer, next best step will be initiate clean intermittent catheterization, consider behavioral modifications like timed voiding, pelvic floor exercises, and review the medication. It is very important. Many drugs with antimuscarinic activity like antidepressants, like tricyclic antidepressants or other drugs may be there. That may be one of the reason for the retention. So the take home message is Parkinson's disease with the LUTs. Treatment must prioritize bladder emptying to prevent chronic retention and its complications. That is the take home message in this patient. My key references are shown here. Stay tuned for further episodes. Thank you.